Hi, Devatam. You ready?
Yes, ma'am. Good evening, ma'am.
Hi. We shall start in few minutes.
Right, ma'am.
I've put it in the group, and once a few more join in, we will start.
Right, ma'am.
Thank you.
చెప్దాం అనుకుని నేను ప్లాన్ అయ్యి ఈరోజు మార్నింగ్ ఎంత 10:30 చేసుకున్నాను. ముందు ఏంటి ఏంటి చెప్తాను అని తప్పగా చేసుకున్నాను. ఈరోజు సార్ డ్యూటీ కదా, ఒకసారి చూపించి ఇంకేం చెప్పచ్చా అని నా ప్లాన్ ఈరోజు కన్సల్ట్ చేసి.
Those in the group right now, if you have yourself or any friend of yours wants to join the FNCG group, the admissions are still active. You may please go to ISCCM site and fill the forms till Feb 15th. Applications are still invited and accepted. Please spread a word. Thank you. Devatam, if you are ready, shall we start?
I'm ready. Uh, let's start.
Hi, good evening, everybody. Dr. Devatam today is presenting in the series of traumatic brain injury. We are towards the end. And Dr. Devatam's topic is going to be prognostication and rehabilitation of TBI. We do not do it ourselves within the ICU, but it's a very important part of determining the functional outcome. So here we are. We'll discuss on this very important aspect of TBI management. Over to you, Devatam. Thank you.
Thank you, ma'am. Good evening, everyone. Myself, Dr. Devottam, and I'm going to discuss regarding prognostication and rehabilitation of traumatic brain injury. The thing is that, as ma'am told already, as an intensivist, we mainly deal with the acute critical illness of any kind of disease. Prognostication is important, very much important for that purpose. But rehabilitation for traumatic brain injury and any kind of neurocritical care patient is very much important, but usually comes after the acute crisis over. And for traumatic brain injury, rehabilitation takes majority of the rehabilitation takes after the patient goes home actually. So usually what we do that in case presented, we initially present a case and then discussion started. But for today's topic, it's very difficult to manage a case presentation for this purpose. So I'm just trying to going to straight into the this topic actually. So we know that traumatic patient with mild traumatic brain injury in all over world, including India, GCS score is 13 to 15. Those who are GCS with 13 to 15, they are mild traumatic brain injury, and most of the patients recover within 1 to 2 weeks. Where in case of moderate traumatic brain injury takes longer time to recover. Approx 60% of the patients have good outcome, and 25% will be left with the moderate residual deficit, and rest of the percentage progress to death or persist in vegetative state or remaining have a severe degree of disability. Now, patients with severe traumatic brain injury have more worse outcome, and only 10% of the patient have a positive outcome in case of severe brain injury. So prognostication is important, but it is not that easy. It's not only based of the GCS score and all. So apart from this, what we do in our day-to-day practice, we give show some parameters and then decide the prognostic outcome. So we can say this is a poor prognostic indicator in traumatic brain injury are age. Age and increasing of the age, there is associated poor outcome, particularly age more than 40 years is called that the patient outcome is not good. Hypotension during the admission, elevated intracranial pressure, hyperthermia, hypoxia, extracranial injury like in polytrauma, and severity of imaging, CT scan brain or MRI brain, brainstem lesion, obliteration of the basal cincture in the CT brain, subarachnoid traumatic subarachnoid hemorrhage, diffuse axonal injury severe type, or a DWI abnormality in MRI brain. These are the parameters that can predict the poor prognostic outcome in traumatic brain injury.
So
And
Devotam,
even, ma'am,
hypothetically, if you take a 60-year-old man and an 80-year-old man, one has come with a GCS of 80-year-old has come with a GCS of 13, and 60-year-old has come with a GCS of 10. 80-year-old has a shrunken brain and has a small SDH, left temporal SDH, whereas 60-year-old has a diffuse axonal injury with minimal subarachnoid hemorrhage.
right, ma'am.
Which one is likely to have a good prognosis based on the indicators you have shown? Also, 60-year-old has had one episode of hypotension with a systolic BP going up to 80 systolic in the ED. 80 years old has consistently maintained a systolic blood pressure of 110. Who is likely to have a bad prognosis?
The
Anybody can
more
answer for
age,
that matter.
uh, increasing of the age, there is a more, ma'am, atrophy of the brain occurs. So there is some space for accumulation of blood and all. So there is a less chance of increasing ICP in those age. But apart from that, there is a hypotension and other things also there. So we have to keep this in mind also. Uh,
So exactly the factors you have enlisted cannot be taken singularly. You have to take all the factors together. So though the age is a good prognosis, comparatively good prognosis for the 60-year-old man, his GCS is lower. Type of injury is a diffuse axonal injury. So the whole brain has undergone a shear injury. That is likely to be the mechanism. And then he's gone on to have a 1 minute hypotension with a systolic of 80. Now that one factor is much bigger deterrent than all the other good factors he had. Whether you take the age or GCS or whatever you take, it is the hypotension which puts him into the bad prognosis factor. Now, the factor that you said about the 80-year-old, that the brain is atrophied and there is space, so ICP will be low in this. Remember, this person has lived with that atrophied brain all the time. So his baseline ICP would be apparently a 15, 12, 15. On that, now you've had a hematoma accumulate, and the ICP has gone up to say 18. Now, this 18 is equivalent to a young guy's 25. So,
Yes,
though
ma'am.
the numbers don't reach there, the prognosis is going to be bad because forever the brain was compliant at a ICP of 12. Now it's risen to 18. That is a very acute rise in ICP for him. So, there is more and more um, talk about a precision individualized ICP target, especially in the elderly where the brain is shrunken. Okay, though radiologically you may not find the features of mass effect, but the other changes within the compliance and
Well,
plasticity changes that occur in brain will be much worse. Please continue. Do you have a case scenario or you are going with a presentation?
no, ma'am. Actually, I don't have case management for rehabilitation purpose and all. I mean,
Okay, okay. Carry
I
on.
don't have.
Thank you.
So, as ma'am already told, it is a very difficult to prognosticate patient with brain injury because it has seen that functionally meaningful recovery, that is, return to the independence, may be possible even if the consciousness is absent in first 4 weeks and more, and even in patient with depressed mental status in the initial weeks following traumatic brain injury. So, according to American College of Surgeon guideline, it is recommended to provide aggressive treatment to the patient with severe traumatic brain injury, including necessary surgical procedure, until the clinical team and the family or surrogate agree that further treatment of this type would not be aligned with the patient values and preference. Not only American College, there is some Neuro Trauma Society of India, and they have also recommendation with the patient with traumatic brain injury, and they are advocating the same thing, the to provide aggressive treatment to the patient with traumatic brain injury because it is difficult to prognosticate basis on the age and other factor at that point of time. So there is some prognostic models for traumatic brain injury, and two are most commonly used. One is crash, and another is impact models. And these models are validated models in the scientific literatures. And it shows, though both the models shows mortality accuracy around 80% and 6 months functional outcomes in the mid 70 to 75% range, whereas the inaccuracy approx 15% for mortality prediction and 25% of functional outcome. Now, impact model, it takes 8 RCT and 3 observational study and 9,205 adults with traumatic brain injury patient with GCS of 12 or less at admission. They have taken in for this model. 6 month outcome measure of 5 categories like Glasgow Coma outcome score, dead, vegetative state, severe disability, moderate disability, and good recovery. Now, the impact model has three core models, three subtypes. One is core model, one is core plus cities plus model, and core city and lab model. In core model, it takes a motor response and pupillary response, reacting, non-reacting, both reacting like that. And motor response is nothing, extension, abnormal flexion, normal flexion, localized, oblique, or unstable. Now, core extended model includes hypoxia, hypotension, epidural mass presence or not, traumatic subarachnoid hemorrhage present or not, and CT classification depending on diffuse injury grading, evacuated mass lesion or non-evacuated mass lesion. Then lab model that includes extended core model plus blood sugar value and the hemoglobin value. Now, result depends on the which type of model we are using. Like suppose there is a only core model is present, CT scan is not available, then we can predict mortality, probability of 6 months mortality and unfavorable outcome in the percentage. Is a algorithm, a software generated calculator, and it gives the percentage of probability displays the percentage. Similarly, core plus CT model and core plus CT lab model depending on number and complexity of the variables. Now, crash prognostic model that is based on MRC crash trial, and it predicts 14 days mortality and 6 month neurological outcome using Glasgow, similar Glasgow outcome scale. The basic model and extended model. It has two model also. Basic model not includes the CT scan or head imaging, but it includes age, Glasgow scale, pupillary reaction to light, and presence of major extracranial injury. Whereas extended model includes, apart from basic model, there is a CT scan features like petechial hemorrhage, augmentation of the third ventricular basal system, subarachnoid hemorrhage, midline shift present or not, or non-evacuated hematoma, like that. This is 2025. Actually, they have another in America. This is the another score, the mortality score for traumatic brain injury, and they have choose age, GCS motor, GCS verbal, eye, and pupillary reflex. 5 parameters they have taken, and the authors are suggesting that this most model can rapidly calculate it and outperforms two widely used models for predicting mortality in traumatic brain injury. Now, as per guidelines, American Society of Surgeons guideline, and they are not recommending using any prognostic model as per their guideline. Because, but they also say that as per, however, the clinician may use this model to describe the predicted outcome probability as estimate only, subject to considerable uncertainty. So these models yet to implement it practically. Now, there is some markers under research. These also try to help this marker
Devottam,
research.
sorry to interrupt. Now, till the last slide, if we were to consider, and you go to a patient tomorrow, how will you prognosticate? You have talked of almost 3 scales. Now, based on that, tomorrow you see a patient. How do you approach the patient's relative? How do you say what is the likelihood of survival or functional outcome?
As per guidelines, these models are not recommended, and we usually in our hospital don't use these models for prognostication. We are still using, I mean, the parameters, clinical condition of the patient, and usually do that way
What is the
prognosticate.
problem? Why are we not using it? So these are all coming from Western world. What is the major difference between patients arriving at healthcare in LMIC versus Western world? There is absolutely no paramedic facility for us. And the time to reach the health services is considerably long. That one factor itself makes a big difference. So when we are not at par at that one factor, the results of impact and crash when we compare with the Western world and the LMICs gets affected. Secondly, I think crash is the one which takes which is the country you're originating from. Is it a developed or underdeveloped? So if you take India, somebody who is working in Apollo is as good as the developed world, where someone who is in a GH, for him the facilities are underdeveloped. So there is no uniformity. So these are the two big factors why we cannot implement this in our setup. Secondly, you said you are not using these calculators and instead you are going clinical. So clinically, how many scores do you know of which can help prognosticate a TBI? GCS is one you already said. What are the other scores that you know of? Anybody can answer. Have you heard of GCSP? Devatam? So why did GCSP come into existence, you think? If you take M2 and M3 in GCS, M3 is likely to have a better prognosis than M2. But statistically speaking, M3 was shown to have lower survival rate compared to M2. And that discrepancy gets corrected if you put pupillary reaction into it. That is how GCSP came into existence. On the other hand, if you have a fixed dilated pupil patient coming to casualty, you have only one bed, you have to maybe decision whether to admit this patient or not, you have to see for brainstem reflexes and see what is the likelihood of he being alive at all, or is he going to become brain dead. In that kind of a clinical scenario, force score will be of useful. Now, please check out what are the components of force score. That is not the realm of
Yeah, yeah.
discussion in
No.
this class.
Mm-hmm.
Please continue.
So there is some markers under research like serum biomarkers and imaging and other advanced technology like serum is 100 beta protein neuron and specific knowledge interleukin 10 myelin basic protein. All these are under research but not in useful in day-to-day practice. Similarly, diffusion in tension imaging, magnetic resonance spectrometry, SSEP, somatosensory evoke potential, and continuous EEG are still in
Please,
study.
please take these serum biomarkers with some seriousness because a lot of research is ongoing and these are on the horizon of making big impacts. Right from you talked about a mild head injury patient. So whether CT scan to be done or MRI scan to be done, to be admitted, to be discharged, what is the likely follow-up? All these things are being looked up with respect to serum biomarker levels. So please keep your eyes and ears open for these biomarkers and the effect in TBI prognostication. It's an upcoming field. Thanks.
Right. Thanks, man. Now, rehabilitation after traumatic brain injury. So, rehabilitation is the combined and coordinated effort of the physician supervised multidisciplinary team is helping a diseased person to reach maximum possible physical, psychological, social, vocational, and educational potential. Implementation of early rehabilitation positively impact length of stay, reduces healthcare cost and resource use, and maximize long-term functional outcomes. Recovery after traumatic brain injury happens in three phases. First phase, there is involvement, activation of cellular repair and reversal of the diastasis. And the second involves plasticity, that is adaptation of the existing neuronal pathway to produce functional changes. And third, involve neuroanatomic plasticity to produce natural connections. The recovery primarily engage ipsilateral brain tissue, but with the more severe traumatic brain injury, it is likely that contralateral brain lesion also recruited. Now, what problems happen after post-traumatic brain injury? Mainly cognitive impairment, upper motor neuron sequelae like spasticity, sleep disturbance, post-traumatic headache and other pain syndromes, psychomotor problems, and psychological sequelae like post-traumatic stress disorder, depression, and anxiety. We come one by one. Now, cognitive impairment is the most common. 65% patients have cognitive
Devatam,
impairments after.
one second.
Mm,
If you were to be sitting in a post-TBI rehab clinic and the patients are coming to you for follow-up, what is the sequence of events you're likely to see? So someone is following you up at 1 month, then coming at 3 months, then coming at 6 months. What are the likely problems they're going to come with? You have written about cognitive impairment and you're going go so on. But what is the sequence in which they will present to you with? For that matter,
First,
what do you send a patient at discharge, a severe TBI you take? At discharge, what medications do they go with?
depending on my residual paralysis presence or not, whether there is spasticity presence or not, any psychological agitation or any problem related to psychological, any problem
No,
or
no,
pain
they
related
don't come
problem.
up in first month. First month is likely to be with respect to the medication you have sent. What is the medication you sent? Anti-epileptic drug?
Yes, ma'am.
Yeah, so first month follow-up usually deals with the toxicity of these drugs. Phenytoin toxicity. If they are children on levetiracetam, a lot of psychotic issues will come up. Okay, the nutrition related, they will come very malnourished. We don't have much of rehab. The family themselves will be feeding, so they are very scared to feed the patient. So they will underfeed. The malnutrition is a big problem. That is the issues you will probably see in the first month. Your cognitive impairment, your behavioral changes, sleep disturbances, they all come in third. And then when you come in the 6 month onwards time, it is with respect to the vocation, social adaptability. Those are the PTSD. Those are the problems in the 6th month. All right. So this is the
Okay.
usual trajectory of problems post-traumatic brain injury. Continue. Thank you.
65% patients have cognitive impairment after traumatic brain injury, and the cognition can be divided into different domains like general intelligence, memory, spatial cognition, function, and social cognition. Most of these domains are affected by traumatic brain injury. Usually, we use mini mental state examination. That is a widely used test that utilized by Indian clinicians for global cognitive screening, both in outpatient setting and also the bedside. It has a maximum score of 30, and below a score below 24 or below is commonly used as threshold to identify any cognitive dysfunction presence or not. Apart from this, Cognistat attends through cognitive examination, three stool, PGI battery of brain dysfunction, etc. tool are used for recognition or diagnosis of cognitive impairment. Now, among these, memory is one of the first cognitive impairment that happens after traumatic brain injury, and it is the last to recover. Prospective, rather retrospective domain of memory gets more affected, and usually donoprazole is a drug that used commonly for memory impairments. Executive function indicates all cognitive abilities, which are usually higher order and are for planning and execution. Aware of oneself, planning a task, execution as per plan, judgment of a situation, problem assessment and solving, thinking in the abstract reasoning, and managing own emotion are subdomain of executive function. Metacognitive strategy, group-based intervention, music therapy, rhythmic therapy, etc. are used for rehabilitation strategy for executive function improvement. Now, communication and social cognitive impairment is one of the important impairment that affects the working of the patient. The patient interpersonal relationship, progress in the study, and involvement in the social or community activities can hamper because of this. So, this itself a hurdle for reintegration of the patient into his or her own social system. So training the caregiver in pattern of communication with the affected patient to encourage communication and avoid negative remarks. Caregiver has a great role for this communication to help the patient, help out the patient. Now, as per Indian Society, it's a Neurotrauma Society of India, they have recommended cognitive in rehabilitation should be focused on relevant deficit to ensure those are meaningful to the patient. Intricate strategies to promote the generalization of skill. Group intervention can be looked into the targeted of improving skill, improvement of self-regulation of the emotion, problem solving, communication, attention, and memory improvement. And it should be reassessed regularly using standardized and functional outcome measures to evaluate effectiveness of intervention. Considering implementation of the non-pharmacological intervention before starting a pharmacological treatment, mainly neurostimulant, dopaminergic agents, antipsychotic, antidepressant. These are pharmacological agents that use for cognition rehabilitation, depending on the situation and complaint.
So with this regard, Devatam, what
Hmm.
would your role be at discharge? How will you prime the caregiver at discharge that with respect to cognition and behavioral changes, what can you expect? Patient has been admitted by you, you've seen the scan, you've treated the patient, now you're discharging. How will you prime the caregiver? Are
As
there
there
any
is a
characteristic CT findings or something that you can help?
uh, there is a different subdomain of the cognition is there, and we have to check the particularly which domain is more affected, and we have to address it accordingly, and we have to
Yeah,
take it.
exactly. So depending upon what the CT scan shows or which age group they are in, Is there any way you can predict how the cognition is going to be immediately after discharge? Any predators? What is bifrontal syndrome? When you have bifrontal contusions and you are sending the patient after observation for say 2 weeks, you can expect that he will have a very different characteristic. I will give you an example. We had one school headmaster who was admitted with us. He was very popular in the school. Gets a TBI, gets admitted with us. We treated him. Went back M6. We thought we did a good job. But when he went back to school, he was very, very aggressive. He was punishing the pupils for no reason. The students were scared of him. A complete 360-degree reversal of his character. So it was our fault that based on what we saw on the scan, we should have primed the family that this could happen. Or if you have a Broca's area involvement, they're going to be mute. They will be aphasic. You have to ask them that probably a sign language, the caretaker also needs to imbibe that to the patient himself. So these are tiny little things. Or if you have a orbital injury and the patient is going back to his work, he will have problems assessing the depth. He has to make a note of that when he goes back to work. Or you can give a letter to the employer that he may be considered for a desk job rather than a side job. These are little things where our input can make a big change in rehabilitation of the patient. Go on. Thanks.
Spasticity, that is the upper motor neuron sequence, and it is a velocity dependent increase in the muscle resistance, which is characterized by increased muscle tone, increased intermittent or sustained involuntary somatic reflex, clonus, or muscle spasm in response to stretch and or noxious cutaneous stimulation. So we use modified Assort's scale for gradation of the spasticity. It is 0 to 4, and depending on the tone, increase tone, slight increase, like that way. Now, what is the treatment? Treatment underlying provocative. There is a multiple provocative factors like pain, poor posture, constipation, incontinence. These things should be addressed, and the spasticity because of these two. So we have to address these things. Passive range of motion exercise reduce motion trigger spasticity, whereas the static stretching using splint or serial casting can reduce stretch reflex activity and contraction. A stretching program can be complemented by the adjunctive technologies such as tendon vibration, muscle cooling, postural adjustment, lift loading, pressure exerted over tight muscle belly, and electrical stimulation of nerves and muscles. Pharmacological like baclofen for lower extremity spasticity are more useful. Tizanidine is effective for the improving upper and lower extremity spasticity. These are more commonly used drug, but there is a second tier of medication including benzodiazepines, trantolin sodium, gabapentin, pregabalin, demonstrate varying levels of the effectiveness that support their potential use in this condition. Now, in the year 2014, it is an extracorporeal shock wave therapy that also introduced a meta-analysis by Kim S. and et al. And they show that they demonstrate immediate and delayed efficacy following treatment with extracorporeal shock wave therapy. Though how it works, it is not explained properly. In refractory cases, surgical intervention like tendon lengthening and tenotomy and tendon transfer that also have been done. Now, sleep disturbance. It is the affect 30 to 70% patients with traumatic brain injury. But sleep disturbance is more common with mild brain injury and in a female patient. Now sleep disorders can be broadly divided into two categories. One is dysomnias and another is parasomnias. Dysomnias are the sleep disorder that cause difficulty in falling off asleep and remaining asleep as well. Whereas parasomnias are the sleep disorder that occurs during arousal, partial arousal, or sleep stage transition phase. Cognitive behavior therapy has been found to be useful for patients with insomnia. Melatonin is the commonly prescribed medication for sleep in patients with brain injury. And recent study and demonstrating the efficacy improve sleep quality also. So what is dysomnia and parasomnia? Hypersomnia, it is divided into as I told earlier, dysomnia is the sleep disorder, difficulty in falling of the sleep. So this narcolepsy, sleep disorder, breathing like OSA, central sleep apnea, circadian rhythm disorder, this comes under dysomnia. Whereas parasomnia is the somnambulism, sleep terror, nightmare, confusion, arousal disorder, these things, REM sleep disorder, behavior disorder, this comes under parasomnia. Now come to psychological sequels. And traumatic brain injury is associated with increased risk of psychiatric disorder, including post-traumatic agitation, major depressive disorder, bipolar affective disorder, generalized anxiety disorder like PTSD, like that. Most common symptom of depression are fatigue, distractibility, anger, irritation. All these things can happen after traumatic brain injury. And actually, it has seen that depression in traumatic brain injury is associated with pre-injury unemployment, poverty, pre-morbid psychiatric disorder, history of depression, alcohol abuse, substance abuse. These things also associated with this. Repetitive transcranial magnetic stimulation is used to treat depression if psychotherapy and pharmacological therapy with SSRI or anticholinergic fails. Use of benzodiazepine and typical antipsychotic medication are not recommended by any society. So we have to avoid these things during the acute phase.
Yeah, so before you label a patient having psychological sequelae, you should rule out any organic cause. So take an instance of a patient who has been decompressed, post decompressive craniectomy. He's gone home nicely ambulant 15 by 15, now becomes little depressed, so-called depressed, not responding very quickly. His gait becomes altered. He is involuntarily micturating. There is bowel bladder control is lost. What will you do? You're going to straight away label him psychological sequelae of TBI, or what will you do if he comes to you?
May not be that, I mean, psychological sequelae, there could be, I mean, pre-discharge condition of the patient, what it was there, and how it
No, he
develops.
was
He
sent,
was
he recovered well, he's been sent ambulant and continent and was 15. Now he's in this manner. What could be a possible reason? He is undergone a decompression also. Hydrocephalus is very common. Normal pressure hydrocephalus, how will he come to you? As the ICP raises, he will become more and more somnolent, less and less active. There will be gait disturbance. He will lose bladder bowel control. So it's very important that before you term them a psychological sequelae and put on antidepressants, you rule out organic causes. And this is very common. Almost 30 to 40% of decompressive craniectomy will go on to develop hydrocephalus, and they will be shunt dependent. So you have to rule out the sequelae of these things as well. Carry on.
agitation and destructive behavior after brain injury. Some person easily become angry, restless, and or excited or behave in manner that is not socially acceptable. So a person may shout vigorously, unable to control his unpleasant behavior. He may eat, bite, and break things without no reason. So it is possible. It may be possible to calm the person simply by talking quietly and comforting and reassuring manner. Soft music can help move the patient to the quiet area and away from the other people until they become calm. Again, avoid benzodiazepine is recommended. Oral risperidone or quetiapine may be given. These are very common finding in ICU during psychological stress management. So now physiotherapy. Physiotherapy has a role in during this management, particularly a great role for rehabilitation of any neurological patient, including traumatic brain injury. Physiotherapy or physical therapy helps to perform physical movement. It can be a part of a generalized pain management plan or specific treatment for an injury. People usually need physiotherapy to manage symptoms of a health condition like pain, stiffness, specific body part input to improve flexibility, strength, balance, and coordination. It could be stretching, stretch training, massage, heat and cold therapy, hydrotherapy, transcutaneous electrical nerve stimulation, etc. Now, walking of after traumatic brain injury, walking is the one of the important part, and it could be initially it could be very tiring. Walk short distance at first and allow the person to rest. Allow to stand and get balance before taking step forward. Specific sit to stand training result in good abilities. Conventional gait training with walker and handheld assistance under supervision with verbal and tactile cues should be done. Aerobic exercise help to reduce fatigue and in social integration, physical independence, level of facility, and overall mental health. So, physiotherapy has a great role for rehabilitation of any neuro patient, including traumatic brain injury. Now comes the occupational therapy. Occupational therapist will help to improve ability to perform tasks to live as a self-sufficiently as possible. It will help patient to get rest, take medication, shop for groceries, driving, use computer and other technology. So occupational therapists help to increase physical strength and coordination of the individual through exercise. Physiotherapy is part of muscle and occupational therapy that makes the patient for his social support and his own performance. Learning to new equipment like prosthetic limb or wheelchair is one of the most commonly usefulness of the help in by occupational therapists. Now, dysphagia, loss of sensory response interference dramatically impairs reflex swallowing ability, and several of these abnormalities often occur in concert. Aspiration risk is increased because of delayed reflex swallowing mechanism and reduced tongue control. In setting of aspiration, the physiologic response is reflex coughing, but aspiration is silent up to 60% patient with neurological impairment. Video sporoscopy is the standard for evaluation of dysphagia. It allows for assessment of intraoral laryngeal or pharyngeal residue as well as the aspiration. It will allow clinicians to define the patient's swallow physiology and determine the most appropriate treatment and optimal diet. Another instrumental assessment, fiber-optic endoscopic evaluation of swallowing also uh, happens in some places. Treatment with dysphagia include compensatory posture, swallow maneuvers, tongue exercise. Resistance exercise for tongue have been shown to improve swallow pressure, airway protection, and lingual volume. As per guideline of Society of Neurotrauma in India, Neurotrauma Society of India, and they have advised to encourage the patient to take one sip or bite at a time. Help the patient to lower chin down towards the chest during swallowing. They also recommended to give liquids by spoon or straw. Ask the patient to swallow 2 times for each sip or bite. They also recommend to breathe it, hold it, and then swallow and rebreathe. Check between swallow and after the meal to make ensure no food left in the mouth. Offer one item of food at a time. Do not talk while eating and drinking. A caregiver should remain with the patient to assure that patient eats and drinks safely. Assist the patient to sit upright for 30 to 60 minutes after eating to ensure proper feeding and prevent aspiration. Swallow and speech therapist has great role for during this phase. Uh, they speech and language pathologists work closely with children and adults who have various level of speech language communication problems and with those have swallow drinking and eating difficulties. They help to articulate the word, improve fluency, voice control and modulation. Comprehension and expression of language, ability to of swallow and reduce risk of aspiration. Now, bowel bladder incontinence. Morbidity associated with bowel bladder incontinence includes skin irritation and wound development, risk of infection, increased caregiver burden. This condition can increase social isolation and negatively impact psychological well-being of the patient. So patient should be on bowel management regimen that include timed elimination and motility and debulking agent for bowel and bladder management. Commonly traumatic brain injury develops a hyperreflexive bladder and present with frequent small volume voids. As a result, cortical injury above the pontine micturition. So this condition has a good prognosis and ultimately resolved, but may require anticholinergic agent initial months for the following the injury. Urinary retention may respond to alpha adrenergic receptor 1A antagonist or type 2 alpha 5 alpha reductase inhibitor for men. So blood and power incontinence to be looked after seriously, and not only this medication but also the proper hearing and proper skill development of incontinence is required. Now come to the pain syndrome. Managing pain with traumatic brain injury is challenging because cognitive impairments co-found the evaluation. But pain limit recovery by restricting patient participation in the rehabilitation process. Headache is the one of the most post-traumatic headache problem. It could be acute or chronic. All type of features of primary headaches may occur, like like migraine headache, tension headache, cervicogenic headache. All things, all type of pain can be present in post-traumatic as a post-traumatic headache. Treatment again mainly NSAIDs and prophylactic beta blocker, calcium channel blocker, anti-epileptic medication, antidepressant are used. In case of chronic post-traumatic headache, treatment with botulinum toxin injection is usually can used in Western world. Now,
So here there
neuropathic
is
pain
another caveat. There is another caveat. Patients who present with anterior cranial fossa fractures, and many a times they have very minimal CSF leak, one or two drops rhinorrhea, and then it settles there. Or they have only post-nasal drip, which many a times doesn't even get evaluated clinically. We don't even notice. In such patients, even 2 to 3 weeks after discharge, they can come with new onset pain, new onset headache.
Mhm.
Fever may or may not be there, new onset headache, and sometimes recurrence of uh, rhinorrhea. They are very likely to have meningitis. So when the patient comes to you with pain, you should always make it a habit to look back on the bone window of the patient and make sure there is no likelihood of any possible fractures which can present with delayed meningitis. That is one clinically treatable and completely recoverable condition, which if not treated, 100% mortality. Yeah. Continue.
Now, neuropathic pain that may be defined as pain caused by primary lesion or dysfunction of the peripheral nervous system or CNS due to neuronal hyperexcitability. Usually, tricyclic antidepressant, SSRI, gabapentin, pregabalin, these things are used. In intractable cases, deep brain stimulation, implanted drug delivery system, ablative therapies are enrolled. Direct trauma from inciting incident or compression neuropathy from positioning during neurosurgery or during recovery during hospital stay leads to compression neuropathy like ulnar brachial plexus or sciatic. Complex regional pain syndrome. It is a painful disorder often developed as a disproportionate reaction to the trauma. It is typically affect the limbs and characterized by severe pain, allotonia, hyperalgesia, edema, tropical screen changes, disorder of the blood flow, and sweat regulation. Mainly two types. Type 1, that is reflex sympathetic dystrophy, is more common and may occur with a soft tissue injury or a fracture without focal nerve damage. And type 2, causalgia associated with injury to a peripheral nerve. Treatment is mainly aggressive physiotherapy and occupational therapy, and possibly pain psychiatry may needed. Ganglion block, surgical denervation may needed in severe cases. Now, national guidelines for management of traumatic brain injury. This is the Indian guideline. As I discussed through this guideline only, and recommended to decision to discontinue care should not be made at least 3 months after injury for prognostication purpose. Decision to discontinue care should be made after repeated consultation with the neurosurgeon, social worker, psychologist, and the family. Skincare, according to them, skincare is, as we know, it's also part of the portion of the rehabilitation purpose. Daily skin check for pressure sore, wash all open sore area uh, with a topical agent if it is infected. All these are recommended. It's important to clean the wet or solid skin immediately after urination or bowel movements because there is a
So
chance
part
of
of
collagen.
part of skincare, what do you advise them at discharge about the scalp care, especially if they've undergone a surgery?
Removal
Usually
of
what we
stitch
do is, yeah, go on.
after removal of stitch, it can they can use normally, but
Do
prior
you
to
keep your
removal of
patients in the hospital till the sutures are removed?
no no no. I mean after prior to removal of the stitch, it is better to avoid the using soap. Only soap can apply, and after that they can use shampoo and all. Everything can be allowed after the removal of the stitch.
It is often a forgotten thing, and the family, for the fear that the sutured site could become infected, don't give them bath. And in Indian humidity, it becomes a very potential site of infection. So you have to clearly tell them that everything that you would have done before the injury, you should resume back, including taking bath and shampooing your hair.
So
So rather than the skin, what do you call, dependent decubitus ulcer, what is more important is the scalp cleaning and the suture site care.
clean
Continue.
care. So it is important to turn the person in bed every 2 to 3 hours. Splinter use, we have to also check the prevent deformity to ensure there is a soft padding to avoid injuries and due to the splint itself. And it is to ensure the patient gets quiet and monitored environment to and good sleep is important. Washing, bathing is daily washing is essential for the hygiene purpose. Cervical side need to be washed daily to prevent infection. So care to prevent choking and facilitate breathing. So patient who cannot move spontaneously should lie in position that helps easy for breathing. Move pillows and blankets away from the face and that can suffocate and lead to suffocation hazard. Use roll blanket to rise the head and chest if patient is like that. Use sitting position for feeding, drinking, and keep patient upright for 1 hour after feeding. If the patient vomit, quickly turn on the side to avoid aspiration and choking. Usually left lateral position. Management of urine and fecal matters, to make certain that patient having regular urination and bowel movement, fruits having good fiber content and helping the bowel motility, encourage water intake several times a day, and temporary catheter may be needed for urinary retention. That's all.
So again, one hypothetical situation where you have depressed the patient and the family says that when he is sitting up, he's absolutely fine. But when he lies down, he becomes less responsive. What will you do? What are you thinking of? Or
Postural
rather
hypotension
opposite.
could
Or rather opposite. He is good while sleeping, lying down, and when he sits up, he becomes disoriented and drops his score. Probably sunken flap syndrome. So many a times, all the behavioral changes and mentation issues that you talked about get corrected when you do cranioplasty. This is an understated treatment. We save lives with decompression, we just let them go. The treatment is not over till a cranioplasty is done. There is a small number percentage of patients who actually worsen after cranioplasty. That is a fact. But the sooner you do, and depending upon the kind of flap you've used and reduce the infection rate, there is a high chance that the patients will improve their mentation. And the chances of them developing hydrocephalus reduces. So when you talk about physiotherapy and mentation issues, you have to also talk about the role of cranioplasty in it. Otherwise, so the bottom again, this whole presentation was supposed to be a case-based. So it will be much appreciated if all of you begin the presentation with case and end with literature review. This is not a
Yes,
lecture,
ma'am.
so make it that way,
Yeah,
please.
I
The
know, ma'am.
engagement
Actually,
is much better.
yeah, but actually, ma'am, rehabilitation is not that we commonly use, so I
No,
cannot get
don't,
it properly.
don't. You just take a decompressed severe head injury patient and we discuss the possibilities of what issues could come up while we follow up the patient. We may not actually have a rehab patient. Then also
Okay,
there is
ma'am.
issues of tracheostomy, track care, WAP. We are not going into spinal cord injury. There, your bladder bubble and all become much more. We're not talking about that. We're only talking about brain injury. In that case, the issues of tracheostomy and WAP also become very important. Anybody has any other issues to talk about? You, Devatam, have anything to clarify?
That's the thing. Actually, I initially thought I do have doubts regarding the presentation I have made because I mean, the rehabilitation portion I was little confused how to make the proper. I mean, what is important for exam purpose also. As I told you, it is not our daily job to see this kind of patient in follow up. So
I agree.
I was little confused.
No problem. So, again, since finished with the discussion, re-emphasizing if you have any colleague who is looking for neurocritical care course, the slot is open for admissions. Please tell them till Feb 15.
Sure,
If not, thank you very
sure.
much for the presentation. We did have a good
Thank
discussion. I think we've covered all the parts of TBI related rehab.
you.
All right, we'll meet in another 2 weeks. Before that, there is national conference coming, critical care. Hope to see
Yes,
you for the
ma'am.
workshop.
Sure, ma'am. Sure, ma'am.
Thank you all.
Thank you,
Good
ma'am.
night.
Thank you.